Welcome to everyone that is joining us. This is the Infection Prevention Strategy Masterclass webinar, Protecting Dental and Medical Staff, Patients from COVID-19. We will begin shortly. Hello, thank you everyone for joining us. We are going to go ahead and get started. Welcome. This is the Infection Prevention Strategy, also known as TIPS, Masterclass webinar entitled Protecting Dental and Medical Staff and Patients from COVID-19. Your participant lines have been muted. This presentation will last about 50 minutes, and we were going to follow for about 10 minutes after for questions and answers. So please type your questions in the webinar panel labeled Q&A. We will follow up after the webinar to address any questions that we're not able to answer during the webinar. My name is Amber Riley. I am going to serve as your moderator this afternoon. I'm originally from Dayton, Ohio. I'm a graduate of Sinclair College in dental hygiene, and then I completed my baccalaureate with Wright State, also in Dayton, Ohio, and my master's degree from Boston University. I now live and practice in San Diego, California. I'm a subject matter consultant with over 20 dental boards in the United States, and I also am a forensic dental consultant for the San Diego County Office of the Medical Examiner. I'm a fellow of the American Academy of Forensic Sciences, and I'm a member of the California Dental Hygienists Association. I lecture nationally and internationally, and I hope to return to that one day soon, covering evidence-based, oral systemically focused topics for dental professionals. I lecture in forensic odontology as well as oral pathology. The learning objectives for today are posted on your screen for convenience. Give you just a couple of seconds to read over those. By participating in this webinar, you acknowledge that the statements and information provided is for general guidance purposes only. The coronavirus situation is evolving and it is dynamic. You're advised to contact your local government and regional health authority for specific instruction on all of the topics that are mentioned in this webinar. This webinar is not to replace the guidance and direction of your local government and health authority. This webinar series is hosted by the Infection Prevention Strategy, also known as TIPS. Dan, do you want to provide information on TIPS right now?
Yes, thank you, Amber. This is Dan Mueller. I'm with Garcia Medical. I'm also a TIPS board member. TIPS is a non-for-profit organization existing to advance innovations, ideas, and processes which make a difference in global health. TIPS extends to over 30 countries and is the key strategic partner for many notable organizations, initiatives, and events. In the past few years, TIPS has contributed millions of dollars.
Our other panelist is Dan Mueller. He's with Garcia Medical and is also a TIPS board member. TIPS is a not-for-profit organization, and it's existing to advance innovations, ideas, and processes which make a difference in global health. TIPS extends to over 30 countries and is the key strategic partner for many notable organizations, initiatives, and events in the past few years, TIPS has contributed millions of dollars worth of scientific impact through various programs, and you can learn about their successes several ways. You can use their open access journal, that's at infectioncontrol.tips. You can learn about them at conferences such as the HITS conference through Masterclass Events, which is at masterseries.events, or there's a podcast series as well. So
Amber,
this webinar
Amber, can you hear
series
me?
is
I had an
sponsored by
audio
Kirsten
issue.
Medical, manufacturers of NADCC, which is a fast dissolving tablet for water. This surface disinfectant is used across the United States and globally. It is EPA approved sporicidal for emerging pathogens and virus, which includes our friend currently SARS-CoV-2 and also biofilm. To get more information from the audience, I would like to put up an anonymous polling question just to get to know you a little bit better. So please just choose what role that you have in your professional capacity. This is just to help the panelists get a broader sweep of exactly who we're talking to. Thank you very much. And without further delay, I would love to introduce you to today's speaker, Dr. Jeff Williams. He has had a long career in academic microbiology and infectious diseases. From his position as professor of microbiology and molecular genetics at Michigan State University, he remains active as a technical advisor to several companies in the Seattle area, and he specializes in the areas of antimicrobial chemistry and disinfection. He is the author of over 200 scientific papers and textbook chapters. He has served 4 years as a member of the Board of Counselors to Dr. Tony Fauci with the US NIH Institute of Allergy and Infectious Diseases, and he is a frequent consultant to the World Health Organization of the UN in Geneva, Switzerland. He holds degrees in veterinarian science, in pathobiology, where he earned his PhD at the University of Pennsylvania, where he was a Fulbright Scholar. Dr. Williams, it is my pleasure to hand the floor over to you, sir.
Thank you, Amber. I'm just clicking on my share here so that you can let me know if you can see what I'm wanting you to see. Is that clear now? Do you hear me?
Great.
Okay, good. So I'm going to try today to create a bit of context to the theme of the presentation, which is protection of patients and staff, and give you the sort of big picture of that new context that we're in right now in this corona era, and specifically how it relates to the dental office. And the first question I'm going to pose is, how did we ever get here? We're in an era of virus pandemics. We're in the era of post-antibiotic drugs. We have totally drug-resistant yeast infections that have spread around the world. How did this happen? And I think it starts here. You know, I joined the faculty of microbiology in a big medical school 50 years ago. And I was coming off a few years of being a field scientist in infectious diseases, but the prevailing wisdom at that time is sort of typified by what you see here, that it's over, that the war against pestilence has been won. And this was true from the sort of thought leaders in government and Nobel Prize winners. I joined a department where my medical colleagues could not recruit residents to the infectious disease program because that was considered a dead-end career. And as a consequence, over the 60s, 70s, and well into the 80s, in fact, infectious diseases started to be squeezed out of medical curricula. drug companies shut down their search for new drugs for infectious diseases. People were not being trained in infectious disease, and that perceived wisdom persisted into the 80s. It took, there was a big crack in that perceived wisdom edifice in the mid 80s with the arrival of HIV, which was obviously a watershed moment in infectious diseases and a watershed moment for oral health care. Some big changes came about. And now we're at another watershed and some even bigger changes that are on the horizon. But as a result of that neglect of infectious diseases, we got to where we are. We have antibiotic resistance everywhere. We have the horror of hospital-acquired infections, and we've had some tragic experiences of that with a children's hospital right here in Seattle. We have superbugs that have spread around the world and cause untreatable infections. And the statistics here on the significance of infectious diseases today, you can see just by a glance at those numbers, is actually quite horrifying. During this time then, those decades of neglect, antibiotics were abused. They certainly were being prescribed unnecessarily for lots of conditions that they weren't used necessary for. And that led to, in large part, the circumstances you can see on the screen there. This is an interesting insight, though, into something recent. It surprised me. This is based on a search for those antibiotic-resistant genes. And to simplify the message of that map of the world, blue is bad, dark blue is bad, light blue is good. And what you can see here is when you monitor for antibiotic genes, and you can do that conveniently looking at municipal sewage, what you find is that the antibiotic resistant genes are in the tropics. They're in South America, Africa, Asia. And there's a reason for that. Those of you who've traveled in those areas know that antibiotics are abused on a large scale. You can get an injection of a broad spectrum antibiotic in a village market in most of these parts of the world. So that's an interesting source of the genesis of antimicrobial genes. It took me by surprise that so much of it was being generated in that part of the world. The other thing that's contributed, obviously, is air globalization. And that picture on the left is of a typical scene in some of the clinics a few years ago in an outbreak of Ebola, an infectious disease in West Africa, but that jumped quickly across oceans. We had that Ebola virus then jumping from animals to humans to jet planes, and we ended up with Ebola in Texas and other parts of the USA. So air travel is also a big contributor to where we are today. I think if it were not for Corona, you people in the dental profession would be getting a lot more news and concerned about yeast, about Candida, because there is a Candida now that is highly fatal and totally resistant to therapy. And Candida auris, again, spread like wildfire after it appeared in some of those parts of the world that I mentioned before. And this is a very frightening and troubling development, overshadowed at the moment by coronavirus. Interesting mechanisms here. How did a yeast become resistant to the fungicidal drugs that we would normally have reached for and used to manage that infection? Well, the triazoles, the benzimidazole are the mainstay of what you get sprayed on your fruit. And the likelihood is that this is the source of those resistant genes that are manifested in these highly fatal yeast infections. What I think you won't know, and I hope that there's one thing you take away from this, is this horizontal gene transfer is a term you're going to hear a lot about, because it's highly likely that those yeasts acquired their resistant traits from other microbes in a way that is kind of at odds with what your ideas might be about Darwinistic natural selection. It isn't really as simple as that. There aren't just base changes and mutations in genes that then get selected for. It turns out that microbes sample and integrate very large pieces of other genomes, and they try them out. They take on board chunks of genetic material from the carcasses of their neighbors, and they test them out. And that makes a big difference to how quickly things can be acquired, rather than there being just random mutations that confer benefits. And by the way, I've got a little asterisk there. Maybe we do too. 1 in 12 genes in the human genome originated in viruses. And I think you're going to hear a lot more about horizontal gene transfer and how some of these resistant traits that we're grappling with are acquired. Now, I don't think that's true of the new SARS virus. And that's because it's a simple virus in the sense that it's an RNA strand. But it has done some nasty things and acquired some nasty habits, as you can see here. It made the jump, just like Ebola and some of the other animal viruses, made the jump from animals to humans. It's explosively contagious. And that probably means that the infectious dose is low. And that's because it has a super high affinity for those receptors on the nasal epithelial surfaces. It binds with a high affinity to those surfaces. And but not only those receptors are in oropharyngeal cells, conjunctival cells. The epithelial cells in your conjunctiva and cornea will bind this virus very avidly, but they do bind to lung and internal organ cell surfaces. And how much of those receptors are expressed internally is an important fact, probably in the pathogenesis. It's likely, for example, that in young people and children, the internal expression of those receptors is muted or maybe not at all. And that may explain why young people are so much less prone to the pulmonary and other consequences of the COVID virus. It was circulating, obviously, in Wuhan in 2019, but now we know that it was probably in France in December. It was probably in California in early February. And I think what's going to happen is that people will go into serum archives, probably from patients who had influenza-like symptoms, and take a look at whether, in fact, there were antibodies to corona being developed. It's got some other nasty traits. It's surprisingly able to survive on inanimate surfaces, certainly for days, and in some studies, more than a week. A surprising survival in droplet nuclei, where they remain infective for hours at least, and that's probably going to come back to haunt us and have to be a consideration later on. It's overwhelmingly likely to cause serious disease in elderly patients. So the frail and the elderly are much more susceptible to the disease consequences. I've highlighted in red here a couple of things that are most relevant to you in oral health care. It's highly likely to cause viral shedding in oral and nasal secretions during incubation. So you're going to have patients who are infected, who are not clinically affected, but they've got virus shedding in secretions. And it's also highly likely to cause asymptomatic infections. And that's probably going to turn out to be in the great majority. So again, you're going to have people in your operatory who are shedding, may never develop any clinical signs, but will be disseminating virus into the environment that you're working in. Another step back here to the context, because I think what we've seen is some pretty radical shifts in understanding of microbiology of oral health care in the last few years, driven by new technologies. And it's emphasized, to my mind, two aspects: prevention as a predominant consideration going forward, and the fact that we've got some age-old problems in oral health care management that we got to fix now. And Corona is going to drive that. Here's a little summary of what I think is most significant, and in a way I think quite profound. Those disease associations now, where oral flora, oral disease, are clearly much more significant, both as indicators of systemic disease and potentially causal in systemic disease. And they make that compelling case for more emphasis on prevention. It's the tools of molecular biology that are changing the game. We've got diagnostic gene probes, we've got gene sequencing, fingerprinting. Those are replacing the old-fashioned traditional culture methods that have been used in oral microbiology. We can now trace organisms all the way to office. We can trace them to specific operatories even and instruments as the source of contamination. And I think this is going to drive a really compelling case for better oral health care and better infection control, better prevention. I got a few examples here that I think have cropped up. You've seen all these in the news and in your professional journals. Periodontal disease is an indicator associated not only with the mouth. It's quite clear that knock-on effects of periodontal infections are influencing lots of other disease processes that we're prone to. Everything from cardiovascular, central nervous system. Look at these reports on periodontal disease and decline in Alzheimer's disease, cardiovascular disease, effects on the intimal epithelial cells in the cardiovascular system. All of these, not only now just associations, we're beginning to probe the mechanisms involved in how the products of oral health, microbes influence a lot of other disease situations systemically. Associations and almost on a regular basis, we're going to see and are seeing these associations with other diseases where the management, in this case of lupus, turns out to be affected by the status of the oral health of the patients. And a lot of this coming about from characterization of microbes. We can't grow these, but we can identify them now. We know they're there, and we know what their products are. And some of these are obviously contributing to morbidities such as cancerous growths in the mouth. This is all coming about from molecular biology and gene technology. I mentioned that the organisms of periodontal disease, a lot of them you can't culture. It's old-fashioned to think that you're going to have to characterize them that way, but we can do it using the tools of molecular biology and gene probes. And this is the kind of technology that's led to what I've got in the upper right-hand corner there, a recognition of the explosive appearance of HPV as a major cause of oropharyngeal cancer. We didn't know about this just a few years ago, but now with the tools of DNA, we do. And the little illustration in that graph is to demonstrate that HPV-16 in this instance is so much more prevalent in men than women. And this was an emerging viral infection that now has been overshadowed by corona, but I think is not gone from the scene, and we're going to have to deal with it. We now, and I mentioned that we have probes where we can trace organisms back to their source. Here's an account, a tragic account of Legionnaire's disease in a dental patient. Patient went to the hospital a couple of weeks later, ends up with a fatal Legionella, and the alert physicians in this case realized that there was a link. They went back to the dental office and actually identified the operatory that served up the Legionella that caused that fatal infection. These are the kinds of tools that we're able to use and manipulate now that we're in this different era. And aerosols obviously are a big part of what you are concerned about. I know you're all familiar with these kinds of data on the dissemination of aerosols into the environment that you work in, and the way those disseminate and the distribution and the distance traveled is not much less really scary in the era of corona. And in fact, air Air is often, if you take the trouble to sample it, and there's a lot more trouble to sample air than to go around swabbing light switches and armrests, but the air often is much more contaminated than you will find evidence for on surfaces in the dental workplace. And we've known about this for a long time. This falls into the category of some age-old problems that we haven't really addressed, and I think we're going to have to address now. And on the graph on the right there, it gives you some reason why. We now know that these little droplets can suspend in the air and stay infected for hours. Remember that on the right-hand side, that's a particle that's a half a micron. It will stay up in the air all day. And half a micron is, well, coronavirus is 50 nanometers. So you could have a droplet that's got literally hundreds of coronaviruses suspended in the air all day after it's been generated. And we've known, as you see on the left hand there, that these are issues that affect oral health care workers and exposure. We've known for decades that dental assistants, dental hygienists, dentists, are much more prone to have Legionella antibodies than people in the general population. That's not a statistically marginal measurement. It's a very significant difference. And so we're now going to have to deal with this. We've managed not to, in a way, but Corona is going to force a change. And this publication, by the way, just about a month or so ago, kind of seals the fate on that. This is a paper in the New England Journal of Medicine. It's about aerosolization of the coronavirus, actually the SARS-CoV-2 virus itself, and a comparison with the earlier SARS. Remember, we've got a history of SARS going back about 15 years to another coronavirus. But what they showed here at the NIH labs in Hamilton is that this virus can be aerosolized in forms that take the structure of a droplet nucleus, right? Not a large droplet like you might find in something coughed up or sneezed out from a patient. These are droplets that are in that 1 micron, 2-3 micron range, and they stay suspended for many hours, and they remain infected in their experiments for at least 3 to 4 hours. And I think this is going to turn out to be important. It's rather an affront to the belief that the dominant form of transmission is large droplets, because now we know that small droplets can remain infected in the air for a long time. So now a little more specific about this Corona era reality, this new watershed in infection control, because it is new. It's entirely different, and I think it's going to impose on professionals in the oral health care area some requirements, some mandates that will end up modifying office approaches to infection control. And the question is, what are those modes that we can use to protect staff and patients and do it without going broke, because some of them are likely to be quite onerous. So infection control in the new Corona era, and there's some elements of this that Amber is going to return to, but quite obviously when you open up your office again, there are going to be some requirements that will be mandated, will be required for you to deal with both your own protection, your staff protection, and the patients. Patient screening is probably going to be important. Remember, I said that older people, frail people, people with any kind of predisposing condition that can affect their capacity to resist infection are going to be most susceptible to clinical disease. And that's going to require some kind of assessment of that patient, whether that means taking temperatures, taking history, assessing the risk of that patient, I think is going to be an important factor. Obviously, because there is a firm basis in the belief that environmental surfaces become contaminated, touch points convey that virus to your fingers. People touch the face and mouth and eyes with a frequency that leads to that mode of transmission. And as I mentioned, that's a small number of viruses are infective, high affinity for the cells in your nose, mouth, eyes. And that means that there's going to be an emphasis on the efficacy and safety of the formulations you will be using in infection control in your offices. And issues like durability are going to surface. How frequently are you going to have to effect those disinfection measures? Are they going to have to be monitored? Might they be on some periodic basis augmented by a service? And I think you're going to see that in a lot of businesses, a service that comes in and does something that creates rigorously a corona-free environment. There are going to be some office decontamination options that are obviously appearing now to affect coronaviruses in the air and surfaces. I think you'll see these in the form of ultraviolet devices, air filtration systems, chemical air cleansing approaches. These are likely to be onerous. They're likely to be expensive, and they're going to vary, obviously, with different states and their approaches to what requirements you have in the office. But they could be, in some circumstances, quite a burden to opening up again. They're going to be barrier protections, and droplet contamination is going to be something that requires, as you see in the lower left there, the kinds of measures that separate you from patients and can be, and we're seeing these a lot now in public places, provide a protection against droplet contamination. There are going to be a series of options that you'll apply that affect the patient contact between you and your staff and the patient. And obviously, the personal protection devices are going to have to be modified. I think we're going to see an insistence on higher efficiency masks. They're going to be shields. They're going to have to be, in some cases, specialized shields that allow for the kinds of things and manipulations that you do in the dental office. They're going to be antimicrobial masks. And the FDA has approved several technologies for masks that have proven antiviral function. I think you're going to see a need for eye protection, particularly in the circumstances of creating aerosols. And of course, dental procedures are the best of all in creating those. High efficiency masks are going to bring some of their burdens. I don't know how many of you have experienced this already, but high efficiency masks worn hour after hour after hour, it can be quite burdensome. And I think this is going to cause some concerns on the part of staff and perhaps yourselves as to the impact of having something that represents now much more resistance to the normal breathing pattern that you can continue with the looser fitting masks. They're going to be pre-procedural rinses. There are going to be ways that people will use to mitigate the hazards of virus shedding and aerosolization. This is not a very well-defined area scientifically. I think it's true to say that pre-procedural rinses don't have a body of scientific evidence that shows that they actually influence transmission in the dental office. It's more a measure that makes sense, that reducing the number of microbes coming out of the patient's mouth and secretions is going to reduce the amount that is generating aerosols. But it's a gray area from a regulatory point of view. Recommendations are going to be about anything that's available and principally oxidizing agents to reduce the amounts of at this point, bacteria, because these kinds of experiences in the past have been measured in terms of impact on bacterial shedding. We now ought to be more concerned about evidence for virus shedding and virus particles in the air. I'm mentioning a couple of other options here. The waterline, obviously, at the irrigant could be a source of something that could be beneficial in controlling those aerosols. And in addition, because of those developments and the significance of oral health as an indicator and a causal factor in systemic disease, preventive practices for use of the patient at home, I think, will be important. And I want to spend actually the next couple of slides in closing on those emerging options, I'll call them. And I want to focus in particular on something that's been a driving force in my own investigation and research in the last few years, and that is on hypochlorous acid as one of those agents with a potential for contributing in this new corona era. There's a long history and understanding of what we would call oxidative chlorine as an anti-infective agent, and that goes all the way back to World War I. That's really when people realized that oxidative chlorine could be a very significant anti-infective agent and also contribute to wound healing. And those were very empirical observations often made sort of on the battlefield and in managing battlefield wounds 100 years ago. It took a while before, and it was in the latter part of the 20th century, people realized that this entity, this oxidative chlorine, is actually the first responder. It's the primary anti-infective agent in innate immunity. It's what we all depend on as our first line of defense. And that realization was in a few decades ago in the latter part of the 20th century. And at the same time, that recognition that this is a natural product gave rise to a lot of studies on how does it work and how does it not only control infection, but how does it affect healing through triggering the pathophysiological changes that are the cascades of healing enhancement events. And then there was pioneering work done at the USC Dental School some 20 years ago now, almost, showing that those oxidative chlorines could in fact lead to some very significant improvements in oral health. Little bit of the natural history then. We make this in neutrophils, in monocytes, in macrophages, in the microglial cells. All of them make HOCl in this process, complicated process, enzyme-driven, very much a response to the need triggered by the presence of foreign material, viruses, bacteria, fungus that trigger this. And by the way, in the lower left there, there's some recent evidence that maybe this is going on in epithelial cells and some work on nasal epithelial cells that shows that that might be a factor in resistance to coronavirus. What I want to emphasize here, though, is on the right-hand side, some of the research that we've done on HOCl and its efficacy. And you can see it's a pretty broad spectrum of efficacy, quite surprisingly effective. We've published and presented on these findings on the inactivation of prions, but I've got two highlighted there, HPV-16, which is a very resistant virus, very different kettle of fish from corona. This is a virus that resists all chemical disinfectants, including sterilants. And then the coronaviruses, because they are much more susceptible to inactivation, and they're certainly susceptible to HOCl. We've been looking at this spectrum and trying to define dose response, how much HOCl is needed, how long does it take to bring about beneficial effects in infection control. This is from collaborative work with Hershey Medical Center. On the vertical scale, you're looking at what we call the log reduction factor in viral titers. I've drawn a line across there at 4 because that's where agencies like the FDA and the EPA draw a line. 4 log reduction means you have antiviral property. And as you can see, in this instance, the HLCl is bringing about a 5 log reduction. But what was most remarkable to us, and it took us a long time to get there because we started with long contact times. This is HPV-18, another cause of oropharyngeal cancer. But in 15 seconds, we're getting a very high rate of inactivation of HPV. And that augurs well for the role and the potential of applications of HOCl in the current era of oral healthcare and the need for antiviral properties. So what we're doing at the moment, and I'm sure other technologies are going in the same direction, we're sort of leveraging our current use, and we're looking at experiments already underway to answer some questions here. Could pre-procedural rinses mitigate the hazards of virus shedding? And I think, and our aerosolization, this seems likely. Oxidative agents are much more emerging as much more effective than some of the conventional ones like chlorhexidine. We know that this is going to have an effect on aerosolization. There are data, at least dating from bacterial aerosols, that show that. Question is for how long? Might an antiviral agent impact the shedding of the virus sufficiently that it reduces the hazard during a dental procedure very significantly? Certainly a good question, and it's going to be addressed with experiments that are underway. Could waterline delivery of HOCl as an irrigant, could that mitigate the formation of contaminated aerosols? And I think that's possible. But again, we need data. We need the kinds of experiments that we have underway looking at efficacy against coronaviruses in general, and as we speak, efficacy against the SARS-2 virus. And that is going to lead to a better understanding of dose and response and likely lead to some potential applications. And then could the patient adoption of preventive measures so urgently needed, could that be beneficial in helping improve oral health care? There's something wrong when we have such a high prevalence of gingival and periodontal disease in the adult population. We have to be able to do something about that, and putting the onus on the patient to adopt measures that improve gingival and periodontal health, maybe post-extraction improvements. I would say the evidence says yes, that oxidative agents like HOCl can contribute to that. We're seeing that with some currently available results from its use, but we also see a need for more quantitative and longer-term studies to define those and put some numbers around those changes over time. So this is where I've been focused on looking at with some rigor at the microbiology of infectious disease in oral health care, some specifics looking at the potential for HOCl potentials. And I hope that this has served, Amber, to create a context for what I think you're going to focus on, which is what are those preventive measures that we can plug into this context now.
Thank you, Jeff. Yes, excellent. And while the screens are being swapped out here, I do want to let the audience know, Jeff didn't really bring it up, but Briotech, which is the company that Jeff is the chief scientific officer for, there is a commercially available, extremely stable hypochlorous rinse that I have been using in my practice now for many months. I've been using it myself as just as a patient in my own oral health, but I've been using it in direct non-surgical periodontal therapy, and I've been using it with my patients that in between their root planings, SRPs, fragile refractive perio patients, and we've been using it as an irrigant also in surgery. And I can certainly answer a few more questions about that later on if you have them. But really quick here, just to wrap it up and move on to the Q&As. Returning to dental hygiene services, there are 22 states as of today, as of this weekend, that are open again in the United States to elective and restorative dentistry, which includes some periodontal services. There are 5 states in the United States that did not change their practice model whatsoever during this entire pandemic. So nothing in the United States has been ubiquitous. But right now, immediately, we are still in a declared pandemic emergency. But we are returning to work. We're returning to patients. So right now, the best guidance using the Centers for Disease Control, an associated amalgam of our professional associations, the American Dental Association, the American Dental Hygienists Association, our state associations, think tanks, in addition to the standard medical history reviews. You can't throw everything that we used to do just out the window right now. In addition to the same medical history review that you would always take for your patients. Now, regardless of what the appointment type is, and this is right now during the declared pandemic, we need to take a temperature on every patient that walks in the door. I don't care what their appointment is for. I don't care if it's to try in framework for a bridge. I don't care if it's to try in a night guard. Take that patient's temperature. If their temperature is over 100.4 degrees Fahrenheit, that patient should not be seen. And this is taking a temperature before they enter the clinical operatory. Have a questionnaire available. It doesn't have to be super granular. It can be very generalized, and you're questioning the patient on known COVID-19 history. Have they been tested? Yes or no? If they were tested, when? You know, it matters to me if they were tested in January versus tested in May. Had they been tested for antibodies to COVID-19, to the coronavirus? And record the answers. Record in your therapy record that you've asked the questions and what the answers were. And just to remind my providers out there, my hygienists, my dentists, my assistants, my specialists, my front office, you have the right to postpone treatment to any patient that is not meeting your criteria for health. That has not changed. That is more important now than ever, to remember you have the right to postpone treatment. If you don't feel that patient is up for it, is healthy, they're demonstrating signs and symptoms, and they're pushing back on you that they want to get this work done, remember, you have an obligation to protect yourself and your staff before that patient. Okay, we'll go to the next slide. Immediately during the pandemic, the HOCL pre-procedural rinse, the HOCL that Dr. Williams was speaking about, a 30-second rinse, and use a timer. Just like our patients that that tell us they brush for 2 or 3 minutes and you know it's about 45 seconds, have a timer handy and go ahead and have them just swish a ½ ounce of this product. A little bit goes a long way for 30 seconds. And remember, to my providers, my dentists, my hygienists out there, your PPE, your personal protective equipment, is not your first line of protection against infection. It is your last line of protection. It's what you're wearing, but it's also what you're using when you treat your patients. It's your protection. And this event, this pandemic event, is the perfect opportunity to remind your patients and educate your patients that the new or enhanced or changed procedures that they might be grumbling about are there to protect you. I tell my patient that mouth rinse is there to protect me. It's not there to freshen your breath. It's there to protect me. Okay, go ahead to the next slide. Immediately, there was a question earlier in the chat box, and I knew that this was coming up, so we didn't answer it right away. But returning to restorative and even some elective dentistry, returning to dental hygiene services right now, while we still have a declared pandemic, disposable knee-length gowns or drape, or if you're using a launderable gown or drape, that's perfectly fine, but you do need to change it per patient. The disposable as well. Cover your hair with a disposable cap or a cap that can be laundered. An N95 mask is ideal, but the supply of this is still extremely scarce. And an N95 needs to be properly fitted for it to provide you with that high respiratory filtration that it is capable of doing. A full face shield, and I have an example of that. There was a picture that Dr. Williams showed as well, and that is the actual shield that I use, but it's a full face shield over a surgical mask if you don't have an N95. But if you have an N95 right now, the full face shield for all dental hygiene and restorative dental services is strongly, strongly recommended. High volume evacuation. I have used, as a hygienist, I have used high volume evacuation for decades in my practice. I realize though that I am in a minority of hygienists that are comfortable using high volume evacuation. So this isn't too much of a practice shift for me. There are accessories, for instance, a dry shield, Xyrus, which is formerly known as Isolite, the brand has changed, and there are other comparable high volume evacuation and aerosol reduction equipment that allows a provider to still have remarkable control over their aerosol environment, as well as still working alone. The American Dental Hygienists Association recently suggested a guideline for an assistant to be available to assist in high volume evacuation during like ultrasonic scaling. And I'm as great as of recommendation that is, I don't think that it's economically feasible for all practices to have another staff member either onboarded just to assist hygiene, especially when they've been closed for a couple of months and they're in a state of economic duress as well. So using a rubber dam for restorative dentistry as well. We all know how to use rubber dams, but we don't see them a lot in restorative dentistry. But now is a perfect time to break that out of the cabinet and start practicing on your typodonts again. Yeah, thank you, Dan. The next slide. So these are just examples of two of the products that I use. The Dry Shield on the top left, that is a product that I have used for ages and ages. It gives me a bite block. It gives me retraction, and it gives me high volume evacuation. It is just phenomenal. The Xyrus Isolite, one of my docs uses that. It provides the same thing that the Dry Shield provides, as well as some additional light. And then high volume evacuation. That looks kind of like a shorty that's on there. I believe that's a PureVac system. I'm not associated with any of these companies, I will add. I am a consumer. I'm a provider that uses them, but I'm not in any way associated with any of these companies. But you know, this I do think will be a normal that evolves with hygiene, especially as we move from the pandemic into our practice after the pandemic is behind us, is that you will learn to love high volume evacuation. Okay, Dan, next slide there. Thank you. Okay, and this is an example. So I had a question a couple of days ago that came in prior to this webinar when we were finalizing our slides about the face shield and loops. I have worn through the lens loops for the last 14, 15 years of my clinical practice. And the face shields usually sit very, very close to the face, so much so that the contact between the facial barrier and the loop was touching, or you'd have such a magnification of scratches or something like that on the plastic shield that your vision was actually worse when it should be better. This particular company, Ultralight Optics, is out of San Clemente, California. This is a company that I do work with from time to time, and I'm certainly happy to disclose this, but this is the exact shield that I use with certainly during a pandemic and afterwards, and it fits well over through the lens loops, and I can either mount my light on top if you want the light on the outside, which is the way I like it, but it's also fine to just pop the shield on and go. You'll have a mask on under this. CDC guidelines would allow just a surgical mask worn under the face shield, but right now, if you have access to a quality N95 and you know how to wear it, then I would recommend both. Go ahead thank you. The front office aerosol barrier. This is a colleague of mine. This is an oral surgeon that my practice works with collaboratively on a daily basis. And while his practice was also a little bit slower, he took the time to do 3D printing aerosol barriers for all of his referring offices, and even came and personally installed them for us, which was outstanding. And so this is a temporary barrier. This is something we're doing now. It's not something that we intend to keep up in the long term. You can see the stanchion clasps on the bottom. All of that is a porous, semi-porous material. It can be wiped down, sanitized with surface disinfectant, which they're doing hourly on both sides. And then the front office personnel there in his practice is also wearing a surgical mask, but she's behind the barrier. And Dr. Williams talked about what are your protocols for frequency of decontamination. That's something in your practice that you want to just have a checklist. Just like all of us in practice have a checklist on when was the last time we shocked the water lines, when was the last time we checked we ran the sterilizer microbe test, things like that. Right now, you're going to want at least an hourly checklist on surface disinfection in the front and to the back. So a couple of reminders on ultrasonic use. This is a big area of discussion in the United States, and I am seeing some drastically different recommendations state to state to state, from some states saying absolutely no ultrasonic use, to other states saying use critical judgment thinking, high volume evacuation if you're creating an aerosol. So a couple of reminders on the two main types of ultrasonic use. A piezo has two working surfaces and the tip moves in a linear direction. You'll have less heat, less water, and less aerosol. Magnestrictive, three working surfaces, and the tip moves elliptically, which generates more heat, so therefore you have more water and more aerosol. And then, of course, our high-speed handpiece, that just blows both the piezo and the magnestrictive out of the water, which is the next slide. And you can see that kind of an aerosol. So, and again, this is water coming out of the handpieces. This isn't necessarily potentially contaminated, but once it goes into the patient's mouth and blasts back up in our face, then the chances are much higher that it will be. So high volume evacuation, face shields, the tightest fitting respirator that you can have. So right now in our rooms, we want to have no fans in the room, and you do want to strongly consider air purifiers. TIPS is going to be giving a webinar on May 21st regarding air purification, so please come back for that. Patient only in the room whenever possible. Again, we're trying to stay as far away from people as we can. So if you've got a patient that wants to bring their whole family back with them, and in other circumstances you allow it, disallow it right now. Keep your room decluttered, free of magazines, toys, patient education models, paper charts, paperworks, pens, all that kind of stuff out of the way. Just keep your surfaces as open and clean so that you can rapidly decontaminate them and disinfect them frequently. The mouse and the keyboard and the barriers and that kind of thing. If you can put barriers on your mouse and keyboard, that's great. If you can't, put them into a drawer or up in a cabinet until you need to use them. Staggering hygiene appointments. If you've got more than one hygienist working in multiple rooms, staggering the hygiene appointments so that the patients are not arriving and departing at the same time. It's a simple adjustment you can make that will increase distancing amongst patients. It will reduce congestion in hallways. It'll reduce congestion in reception areas, restroom waiting, that kind of thing. The last couple of slides, we've got, sorry, excuse me. Allowing 10 to 15 minutes between hygiene appointments rather than butting them up back to back to back to back to allow for aerosol settling, to disinfect the room. That includes the floor right now. You've got to disinfect the floor of the operatory between every single patient. Run half-time suction line treatments, rebarrier where appropriate, and change your full PPE for every patient. And remember that most surface disinfectants have a label efficacy statement of about 1 to 5 minutes of contact with the surface, so don't rush it, especially in a pandemic. Don't rush it. You want to enter and exit your office in street clothes. Leave your shoes that you wore during the workday in the office. Take your scrubs off in the office. If you're laundering the basic PPEs like the scrubs in the office, that's great, keeping everything there. If you're taking it off-site, or take home in a disposable bag or a bag that may be laundered. Last CDC update was April 27th. That was specific to dental settings. There's really not a lot of granular difference from their first update. I just highlighted the key dental setting updates a couple of slides back. So I think we've got one more, yeah, and then past all of this, when we're back into our usual practice again, please consider the pre-procedural rinse ongoing as just a good SOP that we all used to do, and then we've kind of gotten out of the habit. High volume evacuation with or without associated devices. Back to surgical masks and eyewear, but you may find that you really have developed a love for the shield and you want to keep it as part of your normal PPE. And then you would change your PPE when visibly soiled or damaged as kind of the pre-COVID standard. And since medical history and pathophysiology is one of the areas that I teach in, I would like to encourage everyone here to include a COVID-19 history question on your health history form. We don't know yet what a past history of COVID is going to mean for the future health, breathing, and reactivity of our dental patients going forward. So it's time to go ahead and just put that onto your medical history now, because the data is yet to come, I think, on that. So this is my contact information, my email, and my website. If you have questions that we can't get to that maybe I can reach out to you offline. And if you have interested in any other programs or education that I provide, I'm happy to answer questions. I think we're right at the top of the hour here. So one question over to Jeff that we have is, understanding from your presentation that hypochlorous has been around for ages, quote, a few decades, like you said in your slide. Could you give the listeners a reason why it hasn't moved into mainstream dentistry and periodontal treatment therapies kind of before now?
Yeah, I think when people realized how important it is physiologically, which was maybe 30 odd years ago, began to think about how to make it and use it, and a lot of products appeared that were not very reliable. There were machines that were actually sold to dentists and physicians to make their own using electrolysis as a means of generating it. Of course, in your body, you make it with enzymes. And those were cumbersome and unreliable, and to a great extent, I think they still are. Over about a 20-year period, people began to realize how critical manufacturing was to the purity and stability. And I think poor quality product with a whole mixture of different chlorine species gave HOCl a bad reputation. I think it wasn't until people appreciated that pure HOCl is necessary. It's most potent, but it's also safe. And that's why you can see that combination of unbelievable power in activating things like HPV with a solution you can spray in your eyes or you can spray it on your baby's bottom. I think it's taken a while to reach this point where that purity, stability, and potency are all in one package. And that's what we've been working towards, obviously, for the last few years. And it enables now, when you can scale that process reliably, it enables the kinds of applications that you've adopted and many other people are adopting in both oral health care and general medicine.
Thank you, Jeff. Looking through, kind of scrolling through the questions that are coming through here. I don't want to keep everyone too long after the hour. And a question kind of on the patient categorization of immunocompromised has come through as it relates specifically. The question being, well, who is immunocompromised? Who is your higher risk patient that you would want to either postpone or try to isolate in scheduling? And specific to COVID, again, fall back to the CDC, which is patients over the age of 65 and patients with or patients with an underlying medical condition that's respiratory in nature, such as asthma or emphysema, but patients with brittle heart disease, uncontrolled hypertension, type 2 diabetes that is not well managed. Ideally, if these are patients that you could schedule, say, first thing in the morning, for their treatment, that would be ideal, that you have them in and out before the office gets a little bit more busy. And again, you're reducing risk, you're mitigating risk a little bit there, just to protect those patients during this pandemic. Looks like let's see. Kind of shielding through. There was a question about air purification as well. That come back on May 21st when TIPS is doing a webinar specifically on air purification. Guest account asked the question, Jeff, which tissues in oral cavity shed the COVID-19 or shed the coronavirus? Is it saliva, crevicular fluid, mucosa? Or mainly just droplets from the respiratory system?
The cells in the oropharyngeal region certainly have that receptor on them. The density of the receptors is highest on the cells at the front of your nose, but those receptors are there throughout your sinus and nasal epithelium, oropharyngeal. What we don't know yet, because obviously we've got lots of things to learn, is whether there are proliferative sites that are favored. And we know this for influenza, by the way. The soft palate is where influenza viruses proliferate. And we don't have that kind of data for corona, but we can count on the fact that these oropharyngeal nasal cells are high density, like conjunctival cells. They shed. There's a proliferative stage that leads to virus coming out in saliva and in nasal secretions. So coughs and spluttering and splatter are obviously sources. The other thing we don't know is whether the viruses actually clump together. There's some evidence that a lot of viruses aren't shed as single viruses, but actually in big clumps, and probably increasing the infectivity of them. We don't know that yet. We know that for a number of other infectious viruses.
Excellent. Thank you, Dr. Williams. Dr. Williams has to depart. He has a hard stop in about 3 minutes because he's taking on another appointment. And so we are going to go ahead and end the webinar now. We do have the open Q&As from people that have submitted questions that we have not been able to get to. We will try to answer those directly or reach out to you with an email. Thank you very much for your questions. Thank you for the chat as well. Dan, do you have anything that you wish to conclude with?
No, thanks for everyone attending, and look for more information next in 2 weeks. May 21, we'll be addressing air quality. There were some questions, and we'll have 2 excellent speakers speaking on the topic.
Excellent.
So,
All right. Well, thank you,
thank
everyone.
you very
Have
much.
a lovely weekend and stay healthy. I'll talk to you soon.